Good morning, Mrs. Mahajan, Principal Secretary of Health, Punjab, Professor Chola, Director of PGIMER, Professor Kuman, Head of PGI, School of Public Health, Professor Shankar Prinya, Dr. Firida Tawis, HSD Director of WHO Southeast Asia Regional Office, Dr. Heng Bekedam, Usual Representative to India. Ladies and gentlemen, many thanks for the invitation and my sincere apologies for not able to come to this very important meeting in Chandigarh. Today I will discuss how UC scheme in Thailand was designed and contribute to health equity and health system efficiencies. It is self-evident that President of World Bank Group, Kim Yong-kim, in his speech at the 66th WHA on poverty, health, and the human future, he talked very highly about the Thai USC achievement and its contribution, and also against the technical advice from the World Bank in 2001. But because this is the national agenda, these are the outline of my talk this morning. On the fifth slide, Thailand is an upper middle income country with high level of health achievement in terms of life expectancy and mortality outcomes. Universal health coverage was achieved by 2002 with a comprehensive package and almost zero copay at point of service. Health expenditure is less than 5% of GDP, and the out-of-pocket payment is quite low, 11.3% of total health spending, while public expenditure was 80% of total health expenditure THE. This is increased from 56% in 2001, prior to USC. Under-5 mortality trend between 1990 and 2015 has shown a steady decline. The U5MI is on par with high-income non-OECD country and much lower than the upper middle-income peers. We achieved 12.6 per 1,000 live births in 2015. These slides show that both X and Y axes are the relative performance of child mortality as compared to the predicted child mortality from the regression. The left lower quadrant shows countries scatter plot having above average performance as their child mortality is lower than the predicted value. And you may note that Thailand is at the left lower quadrant of high performing of under 5 mortality in relation to GNI per capita and total health expenditure per capita. Next, similar finding was noted on maternal mortality ratios in relation to total health expenditure and GNI per capita. Again, Thailand is located in the left lower quadrant of above average performance in relation to THE per capita and GNI per capita. In terms of resource input as measured by hospital beds per 1,000 population, Thailand is in the left lower quadrant. So that means its health resource measured by hospital beds is lower than the predicted value, but it is not that low because it's quite at the intercept grid X and Y axis, which is at a zero grid. Similarly to hospital beds per 1,000 population. Health workforce per 1,000 population in 2011 is also lower than the predicted value. So that means both hospital beds and human resource per 1,000 life per 1,000 population is below than the peers. So if we compare health resource input and health outcome performance, it has clearly demonstrated that Thailand is the best by health outcome compared to resource input. In this slide 11, as a result of USC in 2002, the total out-of-pocket payment has substantially reduced from around 30% of total health expenditure to less than 11.1% of total expenditure in 2014. And this is on par with the high-income OECD countries. So that the OP performance as percent of THE is much better and on par with high-income OECD countries. The trend of fiscal space during the period of 2000s and 2010. The fiscal space in Thailand is on par with upper middle income countries, but lower than the high income OECD country. The government revenue was around 20% of the GDP. And the trend is quite conservative without change in the last 20 years. So that means fiscal space for the government is quite a status quo as percent of GDP. Next slide 13. This is fiscal space for health as measured by general government health expenditure as percent of general government expenditure in 2013 was above average when we look at the trend compared with countries having similar GDP per capita. A long march towards USC between 1975 to 2002. It is really a long march. It's 20 years since the first launch of free care for the poor in 1975, when Thailand income was only $390 until we reached USC in 2002, when the GNI per capita was around $1,900. And it is at the bottom of the economic crisis, which is not fully recovered yet from the 1997 Asian economic crisis. Today we have three schemes: the government employee scheme, which is a tax finance, the social health insurance scheme, which is a payroll tax finance, and the rest of the population, which is a tax finance scheme. It is the political decision by Prime Minister Thaksin as his commitment to the 6th January 2001 General Election Manifesto. So USC is really a political decision with a high level at the Prime Minister level commitments. So what are the UC achievements? Slide 16. Despite political conflicts in the last 14 years in Thailand, UC scheme flourished across 8 level governments, 7 prime ministers, 13 health ministers, and we find that the empirical evidence show positive outcome of the UC scheme in all dimensions: pro-poor youth, pro-poor benefit incidents, and minimize medical impoverishment, and gaining health system efficiencies, as well as cost containment. It is very interesting how UC scheme march out through this rough politics in the past 1.5 decades. We have published a number of papers in international peer-reviewed journals. Slide 17 shows the incidence of catastrophic spending as measured by more than 10% of the household expenditure spent on health, it has gradually reduced, and more among the poorest quintile than the richest quintile, I mean the reduction rate. Slide 18 on incidence of medical impoverishment. The upper dot line is the counterfactual scenario, as if there were no UC scheme in 2001. There would be this amount of household impoverished from medical bills, and the lower solid line is the observed data from household survey conducted by National Statistics Office. The gap between the dotted line and the solid line is the net number of households prevented from being impoverished from medical bill as a result of UC scheme introduced in 2002. Slide 19. We see improved utilization both outpatient and inpatient. IHVP works with National Statistics Office to monitor through national household surveys the unmet healthcare needs using a standard survey questionnaire applied from OECD. We demonstrate that the unmet needs was very low and on par with OECD countries. The district health system in slide 20, consisting of health centers for a catchment population of 2 to 5,000 and a district hospital for 30 to 80,000 population in the catchment district. District health system is functioning due to mandatory rural services by all new graduate, medical nurse, dentist, pharmacist, which was introduced since 1972. Policy to recruit rural students for health vocational education and hometown placement has shown very effective on retention of health workforce. Slide 22. District health system, namely health center and district hospital, as a close-to-client service, is the major hub in translating UC scheme policy into a pro-poor outcome, pro-poor utilization, which is measured by concentration index. The minus sign demonstrates utilization is in favor of the poor and vice versa. And then what are the contributing factors? We see strategic purchasing by National Health Security Office is so critical. Slide 24. Budget used to subsidize UC scheme increased from 1,200 baht per capita in 2002 to 3,100 baht per capita in 2014, which is almost 3 times increase as a result of increased utilization rate, expansion of high cost but effective new intervention, and cost increase, in particular the 4% salary increase and 2% medical inflation. So these are the cost driver of cost increase budget per capita between 2002 and 2014. The cost containment is the merit of the close-end provider payment. Capitation is used to pay outpatient services. Global budget and diagnostic related group DRG was used to pay inpatient care. It sent a strong signals to doctor and hospital towards efficiencies to keep the margin. And the downside of potential under provision of services was fully addressed by complaint management, accreditation, and audits. Managing benefit package. Since 2002, its benefit package was comprehensive, where negative list is applied with a small list of exclusion. Linear replacement therapy is exceptional. It is cost ineffective, but it is catastrophic and impoverished to the household. Therefore, dialysis was included in 2006 due to ethical and equity consideration. Otherwise, new intervention to be included as benefit package are subject to stringent health technical assessment using incremental cost effectiveness ratio of less than 1 GDP per capita for one quality adjusted life year gains. When health technical assessment was fully applied using local capacity on HTA, it seems in this slide 27 it seems there's a cascade level of coverage decision. First, it is the cost effectiveness, and then followed by budget impact, and finally health system readiness to provide new services. For example, if cost saving plus low budget impact, decision is yes. For example, lamivudine and treatment of lupus nephritis. If it has proved cost saving plus low budget impact but limited capacity to provide services, the decision is no. For example, implant denture, because it may violate inequity. It may violate equity. If it is a cost effective but budget impact was so high, the decision is no. For example, the treatment of hepatitis C and the adult diaper. The monosonistic purchasing, where a single buyer purchases goods and services from multiple sellers, has a high potential for cost saving given actual quality of services and medical product. National Health Security Office managing UC scheme had demonstrated a capability of negotiating price down with a total cost saving of $188 million during the period of 2009 and 2012. In conclusion, UC scheme has implemented in the context of extensive geographical coverage of functioning supply side as a result of 3 decades of health infrastructure investment. District health system facilitate access, and it is the main hub for both poor outcome. And cross-end provider payment method contribute to efficiency and cost containment. And finally, comprehensive package result in high level of financial risk protection. Slide 30 demonstrates how equity goal and efficiency goal is achieved through different policy intervention as described so far. My concluding slide 31. As UN Secretary General Ban Ki-moon said, he referred to Thailand experience. You don't have to wait to be rich to provide these health services to the people. India income is not that low. India is a middle income country. GNI per capita of $1,610. It is a lower middle income country group, and I would end up with a statement that political commitment makes the impossible USC possible. Thank you for your kind attention, and have a good deliberation in your 2 days conference.